Hello, everyone, and welcome to today's webinar titled Influenza, an Underestimated Threat. This webinar is part of the 8th Coronavirus Virtual Event Series, and I am Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and sponsored by Thermo Fisher Scientific. For more information about Thermo Fisher Scientific, please go to thermofisher.com. Now let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to first participate by communicating with other attendees using our new live chat feature during the presentation. You can find that live chat located on the left of your screen. You can also participate by submitting as many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Submit. Now, in addition to asking questions, we encourage you to participate in our polling question at the end of the speaker presentation. Click on your answer when the poll question is displayed. If you have any trouble seeing or hearing this presentation, just click on that help desk button located at the top of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the continuing education credits link located at the abstract window below the presentation window and follow the process to obtain those credits. I now present today's speaker, Dr. Ari Frenkel, Chief Science Officer at Arcstone Medical Solutions. For a complete biography of our speaker, please visit the Presenter tab from the menu at the left of your screen. Dr. Frenkel, welcome. You may now begin your presentation, sir.
Thank you for the introduction. It's an honor to be presenting today. Before we start, some disclosures, as you can see on this introduction slide. I want to also go into a little bit of my background to provide some context and objectives. We at Arcstone use Prescribe Responsibly as our banner in an effort to bring awareness to antibiotic overutilization and our fight against antimicrobial resistance. But one can only do this if our understanding of infectious diseases and how we treat these infections is optimal. My objective, as always, is to change the way people understand infectious disease so that we can use the best available evidence to treat these infections. I'm a board certified infectious disease physician. I'm also board certified in internal medicine. I've been in the infectious disease space pretty much my entire career. I sat in roles such as medical directors in many settings, including rural hospitals and large corporate settings managing multiple hospitals. I've dedicated my career to antimicrobial stewardship and changing the way healthcare providers prescribe antibiotics. As co-founder and chief science officer of Arcstone, we use technology and artificial intelligence to bring the tools healthcare providers need to understand infectious disease and participate in efficient and optimal antimicrobial stewardship. So let's jump right into it. In the last several years, COVID-19 has been the focus and forefront of public health, medicine in general, and infectious disease. What a lot of clinicians saw almost immediately was that other medical conditions were put on the wayside. Colleagues of mine noted that patients were avoiding care of other chronic conditions in fear of COVID-19. We also saw that COVID-19 was the focus of infectious disease testing, while many other respiratory pathogens were and still are capable of causing diseases, many of which present similarly to COVID-19. Many patients with viral upper respiratory symptoms would obtain COVID-19 testing, and when negative, workup was discontinued. With no underlying diagnosis and no additional testing for other pathogens that may be contagious or cause similar symptoms. Influenza is one of those pathogens that can present very similar to COVID-19 and can be overlooked if COVID-19 is the only microbe being tested for. When COVID-19 pandemic started, many people compared it to influenza, and they compared it to the impact influenza had in the pandemics influenza caused many years earlier. Many people are unaware of the history of influenza and that influenza was a significant and still remains a significant threat. In the last 100 years, influenza has resulted in 4 pandemics and several epidemics. The Spanish flu of 1918 to 1919, caused by H1N1, was responsible for 50 million deaths worldwide, including 675,000 deaths in the United States alone. Asian flu, caused by H2N2 in 1957, caused 1.1 million deaths worldwide and 116,000 deaths in the US alone. The Hong Kong flu, caused by H3N2, caused 1 million deaths worldwide and 100,000 deaths in the United States. And lastly, the swine flu, caused by H1N1, most recently in 2009, caused approximately 151,000 to 575,000 deaths in the world and 12,469 deaths in the United States. It doesn't take much to realize that influenza is a global threat. However, we can see in this graph that when we compare each pandemic caused by influenza, there was a dramatic decline in death toll across each one. 50 million deaths dropped to 1.1 million deaths, and approximately 39 years later, when the next pandemic arose, we saw that significant decrease. Only 11 years later, the next pandemic hit, and we also saw a slight decline in mortality. Lastly, in the most recent influenza pandemic, we saw 575,000 deaths, a significant decline in the death toll by approximately over 50%. We may be able to attribute the decline in mortality to modern medicine, vaccinations, and understanding of infection control and public health measures. The widespread exposure to influenza may have helped, as well as the majority of people have had either exposure to influenza or vaccinations, which may help with immunity and also lessen severity of disease and the spread of disease. However, it's important to note that even after 2009 influenza pandemic, we still see thousands of deaths yearly in the United States and worldwide caused by this influenza virus. In January 2011, the CDC estimated that the 2009 H1N1 caused illness in more than 60 million Americans, leading to more than 270,000 hospitalizations and 12,500 deaths. Contrary to typical seasons, 90% of hospitalizations and deaths occurred in persons younger than age 65. So knowing how dangerous influenza is, where did it all come from? Influenza is believed to exist for at least 1,500 years. Some say that Hippocrates described influenza in his works, although many argue that this was not the case. It wasn't until Richard Shope isolated the virus from infected pigs that influenza was actually confirmed. Prior to Richard Shope's discovery, many assumed that syndromes caused by influenza were caused by a bacteria called Bacillus influenzae. And this was what people initially thought the 1918 pandemic was a result of. However, as we know now, that was not the case, and researchers never isolated their suspected bacteria. There are many types of influenza viruses and many subtypes. Influenza A and influenza B are the most common types seen clinically, while influenza C is rarely reported. With the use of advanced molecular diagnostics, we do see influenza C occasionally, however. Animal to human transmission and human to animal transmission is an important element in understanding influenza. Humans can get H1N1 and H3N2, and animals can get these viruses as well, as seen with swine. Horses can get H3N8, dogs can get H3N2, and certain birds can get H5N1. It's important to note that even though many animals get infected with the same virus as humans, they are technically different strains of this virus. The CDC notes that influenza A virus that are typically endemic in one animal species can sometimes cause illness in another species. For example, until 1998, only H1N1 viruses circulated widely in the US pig population. However, in 1998, the H3N2 virus from humans were introduced into the pig population and caused widespread disease among pigs. More recently, the H5N1 virus from birds have caused sporadic infection in wild foxes in the US and in other countries. This is a quote by the CDC. But why is this important? The answer is viral reassortment. Viral reassortment is the takeaway point here. This is an evolutionary mechanism that emerges with interspecies transmission. Genes are shuffled, so to speak, between viruses producing new strains of the virus. So we don't just see this with influenza, but with many other viruses as well. This is a biological mechanism, an evolutionary mechanism. Examples of this are the following. In 1957 and 1968, pandemic viruses have been determined to be reassortment of the avian virus into human virus genetic background. The H5N1 virus circulating between 1997 and 2007 apparently arose from multiple reassortment events among avian influenza viruses. And the 2009 H1N1 influenza pandemic emerged as a result of triple reassortment between avian, human, and swine viruses. When discussing the epidemiology of influenza, it's important to take into consideration how the virus is transmitted, and that is mainly through person to person via large droplets. And as we noted, some interspecies transmission occurs as well. Again, influenza A is found in humans and animals, influenza B and C mainly in humans. Influenza is a seasonal virus and occurs more frequently in different parts of the year, depending on your location. October to April or May in the northern hemispheres, April to September in the southern hemispheres, and year-round in tropical climates. This virus may be contagious in adults one day before symptoms arise, and even contagious 6 to 7 days after symptoms begin. In children, the virus may be contagious 10 or more days after symptoms begin. Here we see a diagram of droplet precautions. This is different than airborne precautions. The distance large droplets can travel in the air is much less than airborne spread. Once the virus enters the respiratory tract, it attaches to respiratory cells, the trachea and the bronchi. When the virus replicates, these cells are destroyed and it results in the virus spreading and can lead to respiratory failure. Because the virus replicates in the respiratory tract, mucus, saliva, and respiratory secretions can carry the virus and spread it from person to person. The virus is typically contagious for 5 to 10 days, as noted before. The virus's clinical presentation can vary from mild, like cold-like symptoms, such as a runny nose, sore throat, headache, fevers, to GI illness, like vomiting and diarrhea, to even more serious diseases, such as pneumonia, respiratory failure, septic shock, myocarditis, and pericarditis. Other key points to note is the incubation period, which is 2 days, and the resolution of fevers, which typically occurs approximately 3 to 4 days into the infection. Most symptoms resolve by day 7, however. The most vulnerable population is patients over 65 years old. Superinfections, or infections that can occur after or with influenza, include Staph aureus, strep, and Haemophilus influenza. Testing for the flu is relatively simple these days. There are typically 2 modalities of testing: antigen testing and molecular testing. How specific or sensitive this test is a way to measure the testing's capabilities. When something is more sensitive, it means the test has the ability to correctly identify the patients with the disease. When a test is specific, it means that the test has the ability to correctly identify people without the disease. According to some studies, antigen testing is very specific, but lacks sensitivity, meaning it can fail to identify patients who are true positive. Stated differently, the antigen test can rule in a disease, but is poor at ruling out the disease, while molecular tests are good for both ruling out the disease and ruling in the disease. New technologies, such as multiplex PCR, allows for testing of multiple viruses and other potential pathogens in a single test using a single sample. So if a patient has respiratory symptoms consistent with a wide range of pathogens, say, for example, influenza, RSV, COVID-19, and rhinovirus, a respiratory panel testing for multiple viruses simultaneously can aid in the diagnosis of this infection rapidly and accurately. This provides many advantages when compared to singleplex PCR, which only detects a single microbe per sample. Management of influenza depends on the clinical scenario, with most antivirals having benefit within 48 hours of symptoms, however. We have many antivirals to choose from, each with pros and cons beyond the scope of this lecture. Tamiflu is the most commonly known antiviral for influenza. Zanamivir is also another antiviral. However, this one can't be given to children who are less than 8 years old or with a history of asthma or COPD. Baloxavir is a newer antiviral and apparently has greater reduction in viral shedding than Tamiflu. It's similar for influenza A, but superior for influenza B, according to some studies. There are some other antivirals, but only available in IV formulation. Of course, supportive care such as symptomatic medications and oxygen if necessary, as well as hydration, should always be provided if needed. Antimicrobial stewardship is key, as antibiotics are not necessarily needed when treating flu. Unfortunately, we see that many respiratory infections are treated with antibiotics, despite the fact that the causes are viral and will not respond to antibiotics. COVID-19 has led to excessive antibiotic use and exacerbation of antibiotic resistance. With that being said, there are scenarios where superinfections do occur, especially when patients improve initially and then deteriorate afterwards. Common causes are strep and staph, as noted earlier. Prevention of influenza is key to stopping transmission of the virus and reducing the intensity of disease. There are many types of vaccines available, including inactivated, live attenuated, and recombinant. Like the treatment of influenza, each of these vaccines have different advantages. However, all people greater than 6 months of age should receive the influenza vaccine, with minimal exceptions. As we discussed earlier, due to antigenic drift, immunity is typically less than a year, with efficacy of the vaccine at 40 to 60% at times, although very variable. Vaccinations of influenza have led to fewer deaths among children and fewer complications in general. Other important modalities of preventing influenza is post-exposure prophylaxis, which is when an individual who may have been exposed to influenza receives antivirals soon after in order to prevent disease progression and possible transmission to others. Contraindications to vaccines include any type of allergies to vaccine component, although typically rare. There is a lot of confusion as how vaccines work, and this can be a lecture unto itself. However, generally speaking, the vaccine stimulates the body's immune system so that when an actual infection occurs, the immune system is ready and prepared to neutralize and reduce the spread of infection, subsequently reducing the risk of transmission. The influenza vaccine is safe, and millions of Americans around the world receive this vaccine for over 50 years. The benefits outweigh the risks, and the side effects of the vaccine have been evaluated extensively and rigorously in many studies. Unfortunately, a recent study has shown that only 50% of Medicare recipients had claims for influenza vaccines, meaning half the patients did not receive a vaccine for influenza. My final takeaway points and objectives of this lecture is that influenza is very dangerous and can often be overlooked, especially within the setting of COVID-19. Influenza has caused millions of deaths in the last 100 years. It has led to multiple pandemics and has the potential to lead to even more pandemics in the future. We have the ability to rule out influenza along with other dangerous viruses using advanced technology and testing. With advances in medicine, we also have many treatment options should one get influenza. But most importantly, vaccines still remain the primary method to prevent severe illness and the spread of disease. I want to thank everybody for their time, and I would like to address any questions anybody may have. Thank you.
Thank you, Dr. Frenkel, for your time today and for your important research. And before we go, we would appreciate our audience participating in a polling question. To record your answer, click on the option on the screen. Our polling question is, would you like a quote or discussion with a technical sales representative about molecular testing solutions for respiratory tract infections? Yes or no? And I will give you a minute to select your answer. And we want to thank you for participating in that polling question. And before we go, I want to thank our audience for joining us. And I'd also like to thank our sponsor, Thermo Fisher Scientific, for sponsoring today's webinar. Questions submitted today and during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand for 2 years until October 19th, 2024. Labyrinth will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and bye-bye.